You're watching CTOM TV. Knowledge is power.
My name is Michelle Morand, and this is Alexander Rowland, the Cancer Guy. We're co-founders of Cancer Treatment Options and Management. It's a worldwide independent research and advocacy organization to link cancer patients and their doctors to the most current advancements in medical science that could benefit them now. It takes typically 10 years, maybe a little less, maybe a bit more, for a new treatment or diagnostic test to make it into mainstream care as a rule. And that's 10 years that you are missing out on those treatments and those tests that could really provide you with a great deal of benefit. The latest scientific data shows that targeted therapies and immunotherapies are far extending cancer patients' lives and providing them with very minimal side effects in contrast to standard chemo and radiation. So there's lots of reasons for you as a cancer patient or a doctor or someone who cares about someone with cancer to make sure that you're using the most current medical science and not just what standard care provides. And that's what Alex and his team do, is they make sure that everybody's getting the most current information. It's all FDA approved, all backed up by good, solid medical science, nothing experimental. And that's why oncologists are happy to prescribe the things Alex recommends. So anyway, what we're here for today is to cover off some things that we hear all the time from cancer patients and their families about some of the things that have come up when they've tried to talk with their doctor about using some of the most important tools of precision oncology, whether it's diagnostics or treatment. So what we wanted to do is we wanted to tell you what those things are so you're prepared for them, some of the things you might hear, and some of the questions you should ask your doctor. And then we want to make sure that you have really good confidence in how to ask those questions and what to do if you hear certain answers. So today is really all about making sure that you have the information you need to advocate well for yourself and make sure that you're using the most current medical science in your cancer treatment. That's our plan. So mostly what's going to happen today, as usual, is Alex is going to be speaking with us about the medical science and the most current stuff, and that I'll interject and try to make sure that it makes sense for folks like you and me who aren't cancer experts. We have Nadine, our teammate, on the chat with you on Facebook, so please just post any questions that you have. And she'll make sure that we get them and we'll answer them in our time today. And thanks very much for joining us. Anything you want to add before we get started?
What do you think of my new haircut?
I think it's nice.
That's from Theo's Hair Stories.
Theo's Hair Stories.
It's a science haircut.
It's a
specially designed scientist haircut.
Really?
He thought I needed a scientist haircut. So the hairs don't drop into my work as I'm on the lab bench.
Oh,
but
great.
It still preserves a bit of length and body, so I look young and youthful.
Excellent. Wonderful. Well, we'll have to tell Theo he did a fine job with your science haircut, Alex.
So I think we have a plan for today. I think that is going to be a good way of going over this.
Okay.
First off, we're going to talk about the different questions you need to ask your doctor when you have a cancer diagnosis.
Okay.
And we're going to cover first the diagnosis, then the treatment, and then the monitoring, and then we're going to talk about clinical trials. And then after we finished, I'm going to ask you 5 questions, Michelle and the audience, and you can do your best to answer. And then we will go over each question in detail, and I will give you an explanation of how best to answer that question.
Oh, crap. There's a
quiz. So there will be a quiz at the end of it.
There's a quiz.
And then we will answer your questions as posted on the internet.
All right. I'm taking notes, as always, but extra notes
So take notes.
Now that I know there's a quiz. Okay. So you said you want to talk about diagnosis,
yes,
treatment, monitoring how well the treatment's working,
exactly,
and then clinical trials.
Exactly.
Okay, folks, have your pen and paper handy, prepared to ace this quiz. Let's go.
Okay, so diagnosis.
Okay.
You've just been diagnosed with a cancer.
Okay.
What do? The first thing you want to do is get your medical records. You want to ask your doctor for all of your medical records whenever you go in for a doctor's visit. And in certain places like Canada, a lot of the medical records are still hard copy and go through traditional faxes that go through actual phone modems.
Right.
So you want to have your records in hand, because a lot of times when you go see a specialist, they're not going to have all of your medical records. So you want to bring them with you. So that's the first take home. Now, the thing you want to ask your doctor, if you've been diagnosed, you want to say what tools you use for diagnosis. So typically that's going to include a pathology, which looks at the cells through a microscope and uses various stains to determine the tissue of origin and ensure that they have the accurate diagnosis of the primary. And then there's also going to be some imaging. And then you want to know what sort of blood work has been done. You know, have they looked at any tumor markers or, certain factors in the blood that can indicate that you have cancer? Then the second question you want to ask your doctor is there any potential for confusion on this diagnosis? In other words, are there other cancers that could also have these same sort of pathology markers or blood markers or imaging? This does happen quite a bit. So you want to ask that just to be sure, just to be on the safe side, if there is a potential confusion or a potential, alternate hypothesis for what you have. Then you want to ask about molecular profiling. And one example of molecular profiling is for breast cancers. So if you have a breast cancer, they're typically divided into 3 different surface receptors. And these surface receptors are the estrogen receptor, the progesterone receptor, and the HER2 receptor. So in a lot of cases, they will give you a percentage of the cells. You want to know that. You want to know if you're strongly estrogen positive or only weakly estrogen positive. You want to know if your PR is strong or not. You also want to know if you're strongly HER2 positive or not. And so you can be estrogen positive. You can be estrogen and progesterone positive. You can be estrogen and progesterone and HER2 positive, which is called triple positive, or you can be triple negative, or you can be HER2 only. So importantly, find out, what molecular features your cancer has. And for example, what percentage of the cells have estrogen receptor positivity? Is it 50%? Is it 90%? If you have HER2, for example, what you want to do is ask, was that IHC, immunohistochemistry, or was that from fluorescent in situ hybridization-based technology, which is a much more accurate way for determining HER2. A lot of times the pathology will be just IHC, and they won't do the FISH. So definitely request the FISH if there is any sort of HER2 expression whatsoever. Now the fourth thing you want to ask about is tumor DNA sequencing. And this is very important because more and more cancers are now being sequenced for certain indications. A lot of the times, what they look for is they'll do a targeted mutation testing to see if you have mutations that will prevent certain drugs from working. One example would be KRAS testing or BRAF testing for colorectal cancers. If you have either of those, then EGFR inhibitors are not going to be beneficial for you. So ask if there's been any tumor DNA sequencing done whatsoever. And if there is, get that information. And then you also want to ask about microsatellite instability, which is a type of tumor that is highly genetically unstable, and also mismatch repair testing. Those are referred to as MSI and MMR, respectively. And what they refer to is mismatch repair is a combination of DNA repair genes. And when they see a mismatch in the base pairs of the DNA, they repair it. So if they're faulty, they're not going to be able to do that, and your tumors are going to have a high number of mutations. And so you also want to look for tumor mutation burden. So if you have a high amount of tumor mutations, together, all 3 of those tests will indicate whether immunotherapy is going to be a benefit to you. Immunotherapy such as CTLA-4 inhibitors or PD-1 inhibitors. Very important because the FDA has determined that anybody, regardless of the type of cancer, that has an MSI high or MMR should get immune therapy. It seems to work in just about every cancer that has those features. So always check and see if that has been done. And if not, request it and offer to pay for it out of pocket. And then finally, if you have a cancer and you're under 50 years old, you want to ask about inherited genetic testing. It's a cheap, easy way of finding out if you have genetic mutations that cause susceptibility. And often, doctors will look at family history and so on, but that's not always the case. You can have mutations in the sperm or the egg that is just a one-shot deal, very much like what you'd get with something like Down syndrome or some of the genetic diseases that are common and involve cancer-related genes. Neurofibromatosis is one of them. And so you want to find out if you have any of these inherited genes, because they can also lead to potential treatment options. For example, if you have mutations in BRCA1 or 2, with a lot of different cancers, you can get PARP inhibitors now for those mutations. So in regards to treatment, we're going to go into treatment now. This is the second section. The questions you want to ask your doctor. Your doctor has given you a diagnosis now, and now they're going to give you a treatment, and they're going to say, here's what we suggest is the first standard care, and it's going to be based on your stage and your type of cancer. So what you want to do is you want to ask your doctor, you want to say, okay, you're giving me this treatment protocol. Now, please tell me the data on this treatment. I would like to see a clinical trial data that shows me the overall response rate. The overall response rate refers to how many patients in that trial have responded to that drug. So if you have a trial of 100 patients and 13 patients respond to that drug, then that means that you have an overall response rate of 13%. That's a very important thing to understand. Then you want to understand what your progression-free survival is. And that refers to the duration of time that a patient is on a drug before the disease reoccurs. And once again, that is a median, so it's a statistic. And so what they do, if they have a trial of 100 patients, and what they do is they give the 100 patients this drug, when 50% of those patients get disease recurrence, they mark that time on the calendar, and that is referred to as a progression-free survival rate. And so it will be given in months. And then there's also the overall survival rate. And that is the same sort of thing, but when 50% of the patients in the trial that have been given the drug die. So important things to know. You want to know, you want to have a copy of the study that the doctor is using to show that this is the best treatment for you. And that is the statistical data you want to understand. And then you want to ask for the peer review studies on that, because that will give you a good indication on how old the treatment actually is. Is it a treatment from 15 years ago? Is it a treatment from 5 years ago? Have they updated this treatment in all that time? Having a study in your hand really gives you a good indication of all of this. And the doctor should provide you with that. The third question you want to ask is, are there any available targeted therapies? And targeted therapies would be based on specific mutations. So let's say you have colon cancer and they tested you and you have a BRAF positive cancer. Your doctor tells you, well, you do have this BRAF mutation, so we can't give you an EGFR inhibitor. But what we now know is that if you have a BRAF mutation, you have colorectal cancer, there's a triplet combination that includes 3 different targeted drugs that works incredibly well for patients with BRAF mutations. Because normally if you have this BRAF mutation, it's a very dire consequence with standard chemotherapy. So you want to ask about these targeted therapy options that are available based on the mutations you have. And then you want to ask if immune therapy is an option. Once again, this boils back down to your MSI, your MMR, and your tumor mutation burden, as well as certain mutations such as ATM or the BRCA mutations or high PD-1 expression, which can all determine whether you're going to be a candidate for immune therapy, PD-1 inhibitors or CTLA-4 inhibitors. And then you want to ask your doctor, are there any clinical trials? And so what you do, if the doctor says, I'm not sure, because there are no real ways that doctors have access to clinical trials. There's no one navigating these for them, and it's very difficult for them to spend the time to look for them. So what you do is you go to a website called clinicaltrials.gov, G-O-V. You type in your cancer, and you do a massive search, and this will give you all of the clinical trials in the world. Then when you find a clinical trial, you can see whether it's being offered at a hospital near to you, and you could print that out and take that information to your doctor and say, I'm interested in this trial. It's apparently a great drug, and there could be potential for that should my chemotherapy fail. Then what you want to do is you want to ask if there's any off-label drugs. In other words, are there drugs that target a specific mutation in a different cancer than what I have, but target the mutation that is in my cancer? So for example, let's say you have a triple negative breast cancer and you find out that you have the androgen receptor on your tumors. The androgen receptor is normally expressed in prostate cancers. But if you have high androgen receptor on your triple negative breast cancer, then that means the treatment for prostate cancers, while it may be off-label because it's indicated for prostate cancers, may be beneficial to you. And we've actually seen patients treated with triple negative androgen receptor breast cancer getting prostate cancer protocols and doing incredibly well on them. So that is referred to as off-label drugs. An off-label drug is a drug that is FDA approved, but it's approved for a different type of cancer other than the cancer you have. But you have a mutation, and that drug targets that mutation regardless of what type of cancer it is. It just hasn't been tested in your type of cancer as of yet. Then you want to ask, for these drugs, is there an option to self-pay? You want to know what your options are, because a lot of times doctors will only give you options that are covered there at that hospital. So there could be a really good drug available, but it's too expensive and it's not covered yet by Health Canada or your insurer. So you want to ask if the doctor knows about any of these drugs. Then you want to ask your doctor, what is being done in other countries? Is this the same standard therapy all across the board? What are they doing at the Mayo Clinic for this cancer? What are they doing at Sloan Kettering or MD Anderson? Or what are they doing in the European Union? You want to find out what else is going on in different countries, and you want to know if your doctor is aware of this. And that's very important information because it can give you a good indication of whether you need to get a second opinion or need to see a different doctor. And then finally, you want to ask your doctor, are they aware of any case studies done through different oncologists? So what case studies are? They're individual drug treatment protocols that oncologists have used on patients and that have gotten good results. They're off-label typically, and they're unique combinations of drugs that wouldn't normally be used in that type of cancer, but an oncologist has found that it's worked really well in a patient that has that type of cancer that you have with the same molecular markers and same genetic features, and whether that case study would benefit you. And so case study is usually restricted to 1 or 2 patients. So it's like a mini clinical trial done by a doctor. So you want to ask your doctor if he's aware of any case studies involving situations that are similar to you. So now we're going to go into monitoring. And monitoring is a very important aspect of cancer treatment. So typically, there's a few different ways that cancers are monitored. They're monitored through blood tests. They're monitored through imaging, standard imaging, typically CTs and MRIs. And they're also monitored potentially in some cases through liquid biopsies, although that is not quite standard practice as of yet. So blood tests typically include things like PSA, prostate-specific antigen for prostate cancer, cancer antigen 125, which is typically used in ovarian cancer, calcinotronin, which is often used in medullary thyroid cancers. There's alpha-fetoprotein, which is good for liver cancers, human HCG, human chorionic gonadotropin, and that's used for germ cell tumors such as testicular and germ cell ovarian cancers. And then there's CEA, and that's commonly used for various cancers. So these are standard blood tests. None of them are specific for a cancer. They're all markers of mechanisms that cancers use. So they can go up and down, and they're not necessarily an accurate diagnostic process. But doctors like to use these just as a way of seeing whether your cancer is moving in a growth direction or a repressive direction. And they do have some value in that context, although they're not that accurate. Mm-hmm. So imaging, typically CT and MRI is being used. And imaging typically includes a process called the RECIST criteria, which goes back to the types of responses you have. And so what imaging does is it looks at the size of a tumor and it monitors it as you go through your growth. And that is what we call serial imaging. And so what they do is they'll do a treatment when you first, they'll do an imaging, a CT or MRI when you're first diagnosed. They'll measure the tumor. And then what they'll do is they'll give you a treatment and you'll come back in 3 months, 4 months, and they'll remeasure the tumor and see if it's gotten bigger. And if it has gotten bigger, or hasn't gotten bigger, the doctors will classify your response under 4 different criterias. And this is referred to as a RECIST criteria. So it's important that you understand the different RECIST criteria responses and that you qualify with your doctor what responses he's referring to, he or she is referring to. So the first one is a complete response. It's called CR. So in this case, the tumor has completely disappeared and that's it. It's responded incredibly well and it's gone. The second type of response is called a partial response. And that's where you get at least a 30% decrease in the size of the tumor. And that's kind of a generalized approach to it, but that's called a partial response. It's still a response, it's still a good thing, but you haven't totally gotten rid of the complete tumor. Then you have stable disease where there's no growth and no reduction. And then you have, and this is a response, it's just a negative response, what's called progressive disease. And that's where you have at least a 20% increase in the volume of the tumor. And that basically means that the tumor is growing. Now, all of these refer to as responses. So when you ask your doctor about the response rates of a certain treatment, you need to look and see whether that response rate includes all of those, which is typically referred to as the disease control rate, or all 3 of those. The 3 are the positive responses, and the 4th is the negative response to progressive disease. So the disease control rate refers to the 3 of those. Now, you want to know what the complete response rate is. Obviously, that's the golden handshake. So if you look at a trial and your doctor says, well, this is a great great drug for you, it has a response rate of 70%. And what you need to ask is you need to say, well, is that 70% a complete response? Is it a partial response? Or is it a stable disease? Or is it a composite of all 3? So obviously you want to know what the complete response rate is because that is the real important thing.
Yeah, it's gone then.
Yes. So this sort of imaging process is standard care. What we recommend is
you mean CT and MRI?
Yes.
Okay.
And it requires a RECIST criteria.
Got it.
Is the basis of the
because
RECIST responses.
They're assessing
measuring
based on the size growth, or shrinkage. Got it.
Not necessarily the best way to respond or to look at a response because the RECIST criteria does not work well with immune therapy. Mm-hmm. And the reason for that is when you get immune therapy, about 30% of patients have what's called pseudoprogression. And that's where the T cells enter the tumor and break it up from the inside out and actually cause the tumor to get bigger. And so the tumors will actually grow in size when they're actually necrotic and dead. A CT and an MRI cannot tell that very well. And so what we always suggest is you get a PET CT along with these CTs and MRIs. And so the PET CT is really important. PET CT provides real-time analysis. In other words, you don't have to get a bunch of different tumors or a bunch of imaging over a long period of time to see if the tumor has grown and find out that the drug you've been on has not done anything and now you have metastatic disease, or the drug is working and you want to stay on it. You want to know that right away. And so a PET CT allows you to do that, and it doesn't require serial sequencing. And that is because the PET CT looks at what's called biological activity. What a PET CT does is it looks at the activity of the cells within that tumor, and it sees if they're highly metabolic. And the way it does that is it uses a radioactive isotope attached to a sugar. And they inject this into you before you get your PET CT. And then any tumors that are highly active are going to drink up a lot of this fluid. And it reports these values in the format of something called an SUV. That refers to the serum uptake value of this fluid. And so this serum uptake value of this fluid has a number. And that number can be used to determine whether that tumor is alive or dead. And so let's say you have a tumor and you get a drug combination, you get a PET CT, and that tumor has gotten bigger over time on the CT scan. But then you get a PET CT and you see that the SUV of that tumor is, 1 or 2. You see that that is actually a tumor that's not very active and it's dying. But you may have another tumor that's very, very small that hasn't grown much, but has an SUV of 28. That is a tumor that you want to have targeted with either radiation therapy or have it removed surgically, because that is a tumor that is likely to grow and metastasize, not the big one. A CT and an MRI cannot tell the difference between these two tumors, and often doctors will ignore a small tumor in favor of a large tumor that may in fact be dead. And this is why you get a PET CT, is it gives you real-time analysis of your tumors. Very important information. And you can look at tumors over time, and often with a PET CT is it will show partial responses. It'll show that while the tumors may not have gotten smaller, the SUV activity has gone down in the tumor over time. And that means you are responding to the drug, even though a CT or an MRI would show that the tumor is the same size. It doesn't matter if the tumor is the same size. What matters is whether it's alive or dead.
How aggressive.
And how aggressive it is, yes. So one problem with PET CTs is if you do have pseudoprogression in immunotherapy, a PET CT is not going to differentiate whether you've got pseudoprogression. And the problem is that the T cells within the tumor that are killing the tumor from the inside out are very active, and they're going to drink up a lot of this sugar solution too. And so they're going to mimic a live tumor. So if you do have immunotherapy, what we recommend is liquid biopsies. And the liquid biopsies we suggest are circulating tumor DNA. And what happens is the dead tumors will release this DNA. We prefer to use exosome-based liquid biopsies because they are a metastatic process. You can learn about exosome-based liquid biopsies on our website and on the Cancer Guide. And we have a website all about liquid biopsies that Nadine can post a link. But any kind of liquid biopsy is going to be beneficial for you when you're monitoring, preferably exosome-based. And that's because they look at the amount of the DNA released by the tumor. And so that is going to obviously change if the tumor is not growing. So if the tumor is dying, then it's this mutation that you're tracking on ctDNA, circulating tumor DNA, is going to decline. And so what you do is you can do a test where you measure your amount of your specific mutation. Let's say you have BRAF and you have colon cancer. You look at that mutation prior to getting treatment. You get your combination of drugs. And if it's immunotherapy, for example, then you look at how much that percentage has gone down over time. Then you know that you're responding to the treatment. And this will work for any sort of cancer. So liquid biopsies really are the future of diagnostics. They don't tell you where the tumor is, but they tell you the overall tumor burden based on the amount of tumor-specific mutated DNA. Now, I'd like to cover one more thing. Clinical trials are a great way of accessing new targeted therapies. One of the important things you have to understand about clinical trials is a drug company is not going to spend a lot of money and get to the clinical trial phase if that drug is not incredibly useful. They have to know in advance and have a lot of data to show that this drug is really going to be much better than what is out there now. So even a phase 1 or a phase 2 clinical trial for a targeted agent or an immune agent can be much more beneficial than just a chemotherapy, a standard chemotherapy. And that's because they've done the pre-testing to get that. Very rarely do clinical trials fail and not show a benefit. It does happen. But in most of those cases, when we look back over those clinical trials, we'll see that the clinical trial was not properly stratified for the patients. In other words, they didn't actually get a population of patients that had the mutation that the drug targeted. We found this out in the early IRESA and Tarceva trials of EGFR inhibitors years ago, where they found that these drugs didn't work, these EGFR targeted agents didn't work, and that was because they didn't check all of the patients to see if they had EGFR mutations. So obviously these drugs are only going to work. So that was a big lesson. Unfortunately, there still are unstratified trials. And so you want to make sure that the trial requires that you have proof of that mutation, and that they test that mutation themselves, or you come to them with proof of that, such as tumor DNA sequencing. So trials, all of the trials these days are based on molecular features. Very few trials are based on the type of cancer. You have basket trials that will look at many different types of cancers with the same genetic mutation. So let's say, a basket trial will look at patients with a BRAF mutation. They have a drug that targets this BRAF mutation, and they will take on, prostate cancer patients, colon cancer patients, breast cancer patients, lung cancer patients, various cancer patients, and they'll see how the drug responds in each group of patients. Often the drug will respond to some degree, but better in certain patients, and that's because many of these target agents are tissue specific and cancer specific. For example, certain cancers such as colon cancer have redundant pathways. And so simply targeting one pathway, which may work in one type of cancer, such as lung cancer, isn't going to necessarily work as well in a colon cancer because it has a redundant active pathway. So you have to use a combination of drugs. And this was shown to us with BRAF. In melanoma, if you have a BRAF mutation, vemurafenib or any BRAF targeting agent works really well. In colon cancers, you can't just give, if you have a BRAF mutation, you can't just give that BRAF drug alone. You have to combine it with two other drugs that target the backup pathways that the cancer cells are using. So you have to use a triple combination of EGFR inhibitor and so on. So, and a MEK inhibitor. So that's because it has alternative pathways. So trials based on molecular features are a good option. And then trials based on the type of disease are not as good of an option unless they include a molecular target. So if you have a specific mutation, like an ALK mutation, and you have lung cancer, and you want to go on a clinical trial, then you want to go and you see a clinical trial that's a basket trial that tries an ALK inhibitor for a bunch of different cancers, or you have the option of going in a trial that has an ALK inhibitor for your type of lung cancer, and you have a ALK inhibitor or an ALK mutation, then you want to go in that trial, not the basket trial. But basket trials are a great way of accessing drugs that are off-label and that don't have a lot of data in your type of cancer. Now, whenever you do a clinical trial, skip the blinded studies. If there's a blinded study, you don't want to go in it. You want to focus on an open label. If it is a blinded study and it is an oral medication, then what you can do is you can take a sample of that and you can send it off to a mass spec lab and find out if you're getting a sugar pill or a placebo or you're getting the actual drug. But you can't really do that with an infusion-based treatment. So I would consider an off-label or a blinded study if it was a take-home oral medication that you could go check. But, I'm all for the progression of science, but really, blinded studies are just not the way to go.
What you're really saying is, in a blinded study, you could be just getting a placebo.
Exactly.
And therefore, time could be passing without you getting any functional treatment.
Exactly.
Or any, additional treatment.
Yes, exactly. So that wraps up everything. Now I have a series of questions for the audience and for Michelle here.
Quiz time.
Quiz time. So go back over your notes, and here's a question that was just recently posed to us, and we hear it a lot. So the patient said to us, he said, we just met with our oncologist, and they said that this type of cancer does not respond to targeted therapies. How would you respond given the information you've just been provided?
Okay. Anybody want to take a crack at this? Okay, I'll give it a try. You guys can weigh in. Okay, so the doctor has said, I'm asking for targeted therapy, and the doctor has said, this type of cancer doesn't respond well to targeted therapy.
Yes. Exactly.
Okay, first of all, I'm thinking I'm going to just revisit, in case I hadn't already, what has been done from a diagnostic perspective for me.
Correct.
I want to see my pathology, my imaging, my blood work.
Mm-hmm.
I want to see if there's any possible confusion with other cancer types that might have similar traits.
Right.
I want to ask what kind of molecular profiling he's done, any IHC or FISH testing, because some are better than others, and I definitely want that to have happened. I want to see, has there been any tumor DNA sequencing so that you can actually know what genes are mutated in my cancer and whether a targeted therapy is going to work or not. I want to ask if there's been any MSI or MMR testing, what the tumor mutation burden for me is. Has there been any inherited mutations testing, which can really indicate targeted therapy options?
Yes. Excellent.
Yeah.
That was great. Yes. So the oncologist is still going to say, you know, we've looked at everything. There are no targeted therapies for this. So how would you respond to this? Well, the first thing you say to them, you say, are you just referring to FDA-approved approaches? Or are you referring to different approaches? What is your data for saying this? You're saying that this cancer doesn't typically respond to targeted therapies. What is your data for that? And then you ask them, you know, are you referring to just FDA-approved therapies? Have you considered sequencing and sensitizing mutations in this cancer, or are you just referring to the type of cancer and targeted therapies? Are you referring to desensitizing mutations? In other words, mutations that would prevent a certain targeted therapy or chemotherapy from working? Are you referring to targeted drugs that are off-label, such as a BRAF mutation in a colon cancer or a lung cancer? In other words, you know you have that mutation. Most people with this type of cancer don't have that mutation, but I may respond because patients that take drugs in different cancers that have BRAF mutations have responded. So maybe I will respond. Are you considering that too? Targeted off-label. Also, have you done any recent peer review research? This is a very important one because a lot of doctors like to feel that they're up on things. But let's give a context here. I mean, there's about 300 different yearly conferences on cancer. They're all based on specific targeted mutations for the most part. Very few include general chemotherapy drugs. They do, but that's not a big part of it. Most of them are specific to a molecular subset in a specific type with a specific combination of drugs. And so 300, some of those, the ASCO last year had 7,000 different presentations or
just
abstracts. One conference. So you multiply, that by 300, you could see the data is overwhelming. And so your doctor that barely has enough time to spend 30 minutes with you and look over your medical records, have they really done a proper peer review research and looked at all of these based on your molecular features? I seriously doubt it. Also, you want to ask them, have they consulted with other doctors outside of their institution? Have they talked to Mayo Clinic and said, hey, what are you guys doing for patients with this type of cancer and these molecular features? These targeted features that this patient has.
Okay, but let's back up the bus. Let's assume they don't have any of the molecular feature information. Let's assume the answer to, have you done these things, the molecular profiling, the tumor DNA sequencing, inherited mutations testing, let's say the answer to that is no.
Well, then you have your answer.
What? My answer is?
What their question is a moot point because they don't have the data.
So
what is their data is the question.
Okay, so if they haven't done these things,
They
and
don't
they're
have
still,
enough data to say that.
Okay, got it.
So ask them if they've consulted with their doctors from different communities, different hospitals, and then ask them if they've looked at patient case studies. So if they're saying this and they've actually confirmed to you that they've gone through this checklist, then you can believe them. But I guarantee you, most doctors won't even get past the first point.
Mm-hmm.
So that's how you address that question.
Okay, right.
Show me the data.
Right. So going in with your list of what data is possible to gather, all those things I listed off, and Alex did.
Have they investigated it all?
Have they looked at all that? Because if all those things haven't been considered, you're almost certainly leaving options on the table.
Exactly.
Or what they're saying.
What they're saying is just not true.
They don't have the data.
They don't have the data to say that.
Right. Yeah.
You know, and they need to retract that statement because they don't have the data to prove that they've done that research to say that.
So it might be true that they themselves don't know of any other options, but that doesn't mean
done the
that
research
there aren't
to
any,
find
and
out.
that's a big difference.
Exactly.
Got it.
So that question could be mistaken many times, and a patient that is going through trauma of a new diagnosis will hear that and think that that's a given and that all doctors are connected to the same brain and they all know the same information. Obviously, that's not the case. Yeah. So I have a second question for you. Okay. And this was put to us recently by a patient. The patient said, our oncologist said that they have worked with these sort of services, meaning tumor DNA sequencing, quite a few times, and they have never seen a treatment recommendation that was different than their treatment plan. How would you respond to that, Michelle?
Ooh, I don't know. Okay, so well, I guess I'd go back to the list we just went through,
right. Yes,
of what they've already done, because that's going to tell me how on the ball they are, how much data they have, and whether they can actually say something will or won't work for me. And what was I doing there?
So they were saying that
new treatment recommendations.
So they were saying, once again, I'll repeat the question. Our oncologist said that they have worked with these sort of services, tumor DNA sequencing, quite a few times, and that they have never seen a treatment recommendation that was different than their treatment plan.
Okay, meaning once they got the test results back,
it did not show anything different than what they were already going to give their patient.
I would have a hard time believing that, for starters, given what I've seen. What's been prescribed versus what changes when we get the data back from the testing is vastly different. So I don't even know how that could be possible.
Okay.
So I'm failing this test.
So how to address this is you ask the doctor, does that mean you have not tried or you have tried?
Have not tried or have tried what?
The recommendations that are different.
Oh, yes, but they're saying there are no recommendations that are different.
Yes, they're saying that they have never seen a treatment recommendation that was different than their treatment plan. Mm-hmm. Okay, so they're saying overall that there's no new recommendations.
Yeah.
Okay, so does that mean if there were new recommendations, they haven't tried them? Because obviously there will be different recommendations if you're doing tumor sequencing. And then you need to ask them, are they looking at clinical trials?
Okay.
So when they say treatment recommendation that was different than their treatment plan, if their treatment plan is standard care, they're referring to standard care for that particular disease. Mm-hmm. They're not considering desensitizing mutations or sensitizing mutations, which are unique to the person. They're not considering off-label drugs. They're not consulting with other doctors. They're not doing that full checklist we just went through. Mm-hmm. They're saying, it doesn't give us the validity to, in other words, it's not a new standard care from this test. Mm-hmm. So it's a bit of a misleading answer.
Yeah, that was a trick question.
It is, but this is what doctors will say to a patient to put them off precision oncology.
But why would they want them to be off precision oncology?
Well, because they can't provide that themselves. Oh. It's not part of what they can do. They're doing standard care.
Okay, right. Yeah.
So, yes, did they look at the mutations, the desensitizing and sensitizing mutations that indicated what chemo drugs they are using would be better or worse.
Mm-hmm. Right. So again, back to our initial list of what they've done for you already from a diagnostic perspective, because if they haven't done all those things.
Yeah. Did they even analyze that report?
Right. Did they look at the sensitizing and desensitizing and all
look at those
other
mutations
things?
and see how they apply to that cancer.
Right.
And then go through all of the points we just went through, peer review research. Or are they just taking the results of the test and saying, this doesn't tell us a new FDA approved indication, so it hasn't changed anything?
Okay, one of the things that you tripped me up there, because Alex is so high level with his knowledge here, and you're saying something that implies an assumption.
The assumption is a new FDA approved protocol, and that is the secret to this kind of question, because this is what standard care does.
Say what?
So the question, once again, our oncologists said they have worked with these sort of services, tumor DNA sequencing, quite a few times, and they have never seen a treatment recommendation that was different than their treatment plan.
Right. Yes. And as you're saying, okay, well,
they're referring to an FDA-approved treatment plan. So you can't possibly get that from a new sequencing protocol. Very rare cases you can, but unless things have changed just recently, you're not going to get that. So obviously, once again, this is a moot point. This is a question that leads you nowhere and is very misleading to the patient.
Well, it kind of tells you that your oncologist doesn't really understand what's possible.
Exactly.
Because they're basically saying, we have a list of things we can offer you, or we have our kind of standard care options.
Yes.
And I have all the data that I need to decide which one of those is right for you.
Exactly.
And there aren't any other options for you.
FDA-approved options.
And yet there are.
But they're not talking about FDA-approved drugs. They're not talking about targeted off-label. They're not looking at clinical trials. They're talking about FDA-approved indications for that cancer.
Right.
And that stage.
Right. And again, on that level that you're talking about, that kind of the surface level, cancer is being diagnosed by location, not molecular features.
Exactly. So you wouldn't expect one of these tests to give them what they think is enough evidence to change to a different FDA approved. So it's a trick question in a sense, a trick answer.
And yet these tests do provide more than enough data.
Of course they do. It's the context that you look at them in.
Yes, what you're looking for.
Okay, I've got another one, third question. Okay. Our oncologist said that this type of cancer is not inherited. How would you respond to that?
Well, so what are they saying?
So we have a patient that is 22 years old and they have a cancer. And, we suggest to them that they get inherited genetic testing. And their oncologist says, there's no point. We're not going to give you genetic inherited testing. It's usually covered in Canada. It could take like years and years to get it, and it's very limited panels. But the oncologist said this type of cancer is not inherited. Now, remember, the way these questions are phrased is really the key here.
Right. So the key, hint, thanks for the hint, is when they're saying this type of cancer, you have to be very direct and clear with them about what diagnostics they've used to find out what type of cancer you have. Did they use everything that was on the list that Alex gave, or did they just use the standard pathology, blood test, CT scan to diagnose you?
Right.
Because if they've just done that, then they're still thinking of your type of cancer from the perspective of breast cancer, lung cancer, pancreatic cancer, brain cancer, not the molecular features for which all the new cancer treatments are being designed. So they couldn't possibly say that. Again, they couldn't say this type of cancer doesn't respond if they haven't done the testing to find out really what mutations are driving your cancer, what's actually causing your cancer.
I think, these responses are worded very well. But if a patient is to hack away and ask them to redefine what they're saying, they will get to the bottom much quicker. So in this particular case, the patient asked the doctor responded with this statement. Our oncologist said that this type of cancer is not inherited. Well, that is correct. A cancer is, only in very, very rare cases, is a cancer inherited. Cancers are not inherited. Genetic mutations in genes that create sensitivity and susceptibility to cancer are inherited. And that is why it's a trick answer. So you can have a BRCA1 mutation, and that is going to increase your risk of certain types of cancers. You may get a blood cancer, you may get a breast cancer, you may get ovarian cancer, you may get many different types of cancers as a consequence of that. If you have an ATM inherited mutation, if you have an NF mutation. So, a cancer is not inherited, but the mutations in the genes that cause the cancer are.
I see.
And so the oncologist is correct in responding that way, but they're completely avoiding the actual issue.
Okay.
So the patient in this case should have said, can you test me for genes that create a susceptibility to cancers?
Right. That's the question. Can you test me for genes that create a susceptibility to cancers?
Yes.
Right. Because that way I'm going to know, okay, I'm going to find out if I have these mutations that create a susceptibility that
that are passed on.
Mm-hmm. Okay.
Or that may be targetable.
Right. So that's kind of a tricky mutation, use of language.
It is. And this is how oncologists respond to precision oncology if they can't supply it. Mm-hmm. So question number 4, and this was recently put to us. Our oncologist said that there are no FDA-approved therapies for this type of cancer apart from what they are prescribing. Mm-hmm. And this really goes back to question 3. It's, once again.
Right. So I'm supposed to answer this?
Yes.
Well, okay.
How do you respond to that oncologist?
Question again was?
Our oncologist said there are no FDA-approved therapies for this type of cancer apart from what they are prescribing.
Okay. So I'm going back to, how deep was their diagnosis? Was it based on location and basic pathology, or was it based on the molecular features? Then I'm going to ask them what kind of research they've done lately, whether they've spoken to any leaders in the field of that particular molecular subtype, or at other major hospitals, like you said, maybe Mayo, MD Anderson. Those would be things without totally looking through all my notes. What are the peer-reviewed studies lately? All that kind of stuff.
Okay. So, but how do you respond to the oncologist? That is the big question.
I just did.
Yes. Well, you're bringing up the reasons for this, but the way to respond to this is you need clarity on what the oncologist is saying to you. So they're saying there are no FDA-approved therapies for this type of cancer apart from what they are prescribing. So the FDA has 2 different approval processes. So they have an FDA-approved drug. And so that drug is approved for a specific mutation. But an approved indication or approved therapy is only for a specific stage, grade, and prior treatment basis of a certain cancer.
Tricky.
So FDA-approved therapies.
I didn't know that. You didn't tell me that.
Yes.
That wasn't in the data.
Well, an FDA-approved therapy is specific to the stage. It's specific to what type of treatments you've already had, and it's specific to the grade and the type, and what you've responded to, what you haven't responded to. So yes, that's a very, very fine criteria to get an FDA-approved drug. However, an FDA-approved drug that is targeted for a certain mutation can be used off-label.
Mm-hmm. Right. So you've got, from the oncologist perspective, or at least what they're sharing with you, you've got maybe 2 options. But if we're thinking bigger picture,
FDA-approved drugs.
Yes, all the possible FDA-approved targeted therapies or immunotherapies out there. There are many.
Yeah.
So again, once you know your molecular features with the tumor DNA sequencing or inherited mutations testing or all those other things Alex talked about, then you would be able to see, whoa, look at all the possibilities.
So once again, you approach this question by asking for clarity. So you say to them, are you referring to FDA-approved drugs that would be potentially beneficial for me in an off-label situation? Or are you referring to FDA-approved indications? And an indication, as I mentioned, has a background to it, based on the grade. So it's important to understand that approval is based on a cancer that has the highest percentage of that mutation. So when they do a clinical trial and a drug testing and an approval, that mutation may occur in many different types of cancers, and it may benefit many different types of cancers. But typically the approval is based on the cancer that has the highest amount of that mutation. So if you have a new drug and it targets a BRAF mutation, and you see that melanoma has a really high percentage of having this mutation, whereas lung cancer has a much lower chance of having this, but there's a lot more lung cancer patients than melanoma patients, the drug company is going to need to say, okay, we need 500 patients for this trial, 1,000 patients for this trial. How are we going to find 500 BRAF positive lung cancer patients? We know we can get 500 BRAF positive melanoma patients because it occurs in a much higher rate. So let's go for the melanoma. The drug may be more beneficial in the lung cancer, but they're going to go with the drug that has the highest sellability, or the cancer that has the highest sellability. Many drugs start out in this manner. And we have so many different drugs that I couldn't even go over them. There's so many different cases where a drug will be started for one indication, and then they'll find that, hey, patients with that same mutation that have this type of cancer also respond to that drug. And patients that have this type of cancer may also respond to the drug. So in the eyes of an oncologist, that doesn't matter, because the drug therapy or indication is for one type of cancer. So even if this drug works incredibly well in lung cancers and you have a lung cancer, they're not going to consider that, and they're not going to tell you about that because it is considered off-label, even though it is an FDA-approved drug. So once again, that gets back to the clarity. What are you saying? Are you including off-label? Are you including clinical trials? Are you specifying indication, stage, grade? You have to really clarify what they're saying when they're saying that.
Right, which is why understanding what you were talking about at the top of the hour, all the possible things,
yes,
they
the
could
diagnostic criteria.
Yeah, yes. When you understand that, or at least have the list handy,
yes,
then you can just run through that list. Is what you're telling me right now
based on these diagnostic factors?
Yeah.
So take that list of diagnostic factors and tests, take it to your oncologist, and with every question or every answer they give you, say, how does that question relate in regards to point A, point B, point C, point D, point E, MSI, all these different diagnostic tests. And I guarantee you they won't make it through the whole list. They'll have, without, changing the answer. So one final question. I think you're going to really do well. This is kind of your bonus question, Michelle.
Thank goodness.
Okay. My oncologist said a PET CT will not change how they treat us. What do you have to say to that? We hear this a lot.
Yeah, we really do. Well, I have some inside scoop here, which is that I know that over 80% of the time is the statistic that I've seen.
Right.
When a PET CT is conducted.
BC Cancer claimed 87.5 recently.
87.5. 87.5% of the time, when you get a PET CT, your treatment plan is modified, which means that, oh my gosh, no math, 12.5% of the time, your treatment plan is accurate.
Right.
Did you hear that? 12.5% of the time.
Not very good.
And even then, we're just talking kind of about location and grade.
Yes.
We're not even talking about the molecular features.
Well, we're not talking about grade.
With a PET CT? Doesn't that help to indicate grade?
Yes. So the answer to this, my oncologist said a PET CT will not change how they treat us.
Right.
So if you go in and your oncologist is saying you're grade 2, and he's going to treat you with a certain protocol, and you go in and the PET CT shows that you actually have other tumors that the MRI and CT did not catch, then, and they're in distal organs, then all of a sudden you're grade 4.
Mm-hmm.
And that means that the drugs they're going to give you, if you're grade 2, are not going to be the same as grade 4.
Mm-hmm.
So a PET CT typically changes the grading in most cases.
Mm-hmm.
We've seen the grading go both ways.
Yes.
We've actually
Yeah.
seen, we've seen cases where patients have been treated based on a CT and an MRI for, lung cancers. And they've gone through harsh chemotherapy and the tumors weren't responding to it. And they were told, you've got literally, 8 months to live. And when we got that patient a PET CT, we found out that they never had cancer in the first place and that it was a benign lump that the doctors were treating. So we've seen that.
Mm-hmm.
We've actually seen doctors targeting metastatic deposits that were not even metastatic. They were just benign lumps, and they've been targeting with radiation.
Mm-hmm. And we've also had the contrary too, where people are told that it's not cancer, it's just benign, and
yes,
go practice some relaxation methods.
Unfortunately,
it's stress.
that is more common.
Mm-hmm.
I just wanted to say that yes, this is how you respond to your oncologist. It's going to change my grading potentially,
mm-hmm.
and that's going to change my treatment.
Yeah.
So it will change how you treat
right.
me based on grading.
Right.
Now, it's also going to change how you treat me based on the fact that it's a real-time analysis and it doesn't require serial imaging.
Mm-hmm.
Therefore, we can get results right away.
Mm-hmm.
We don't have to wait 4 months while you put me on this expensive drug to find out if it's working and the tumors have grown or shrunk.
Mm-hmm.
You can find out in 1 or 2 PET CTs over a period of 6 weeks now,
mm-hmm.
and save a lot of money
mm-hmm.
on that drug if it's not working, or keep providing it with confidence.
Well,
so it's going to change your grading. That's going to affect how you're treated. It's going to change how you respond to the drugs and how you determine if you're responding to the drugs by providing real-time information versus having to do serial imaging.
mm-hmm.
And then it's also going to tell you if you're getting a complete response versus a partial response. Or no response, obviously. And that's based on individual SUV variations. So let's say you get a CT scan and none of those tumors have changed at all. The doctor says, well, you've got RECIST criteria, stable disease. Then you get a PET CT and you say, hey, wait a minute, the tumor on my leg has gone up in SUV. It was 14, now it's 28. And all of the other tumors in my, breasts have gone down. And, they are now, 2 and 1. So now you can just cut out the tumor in my leg and you don't have to irradiate my breast or give me further treatment. So there, by looking at individual serum uptake values of individual tumors, that will change how you get treated. Mm-hmm. Because then maybe they can switch to a different drug or a different approach to treat the tumors that are not responding. Mm-hmm. Or have confidence that the drug they're treating you with is responding, or certain tumors are responding to that. Mm-hmm. And then the fourth way that a PET CT will change how they treat you is with pseudoprogression. So when we first started giving immunotherapy to patients, as I mentioned, 30% of patients get pseudoprogression, up to 30%. And their tumors will grow and expand. And so it was quite interesting in the beginning of the nivolumab and pembrolizumab trials, where they would give these patients drugs, and these patients their tumors would expand, and then new tumors would pop up out of nowhere. And those new tumors popping up out of nowhere were actually just micrometastasis that were too small to be seen on a scan. And then once the immune system went inside of them, it blew them up, so they're now at a much larger resolution or size, and the scan was able to pick it up then. So it looks like they got new tumor growth, but really it's just a tumor that's much bigger because of the pseudoprogression. So a lot of these patients were taken off these drugs and told that they weren't responding, and we've got nothing else for you. And then, years later, these tumors call up their doctor and say, hey, doctor, I'm feeling pretty good these days. And the doctor, what? You're still alive? You're still here? How did that happen? Come in for a scan. We want to know what happened. And so then we started seeing that pseudoprogression was something. So pseudoprogression and PET CT, as I mentioned earlier, is a tricky thing. Pseudoprogression can be used for brain tumors because often brain tumors, that may or may not respond to treatment, pseudoprogression is a good way of seeing if that is necrotic tissue. So pseudoprogression a PET CT will only determine pseudoprogression after the immunotherapy has finished its job. So if it's actively causing tumor or infiltration of TILs, CD8 positive tumor infiltrating lymphocytes, then it's going to look hot on a PET CT. But once that tumor is dead and the immune system is not attacking it anymore, it may still be the same size tumor, but then the PET CT will tell you that. It will tell you this is necrotic tissue, it's dead, it doesn't have any SUV value, therefore it is a dead tumor and you have responded. So once again, a PET CT will change the way you get treated based on its ability to determine whether pseudoprogression has occurred.
So that's kind of a timing factor then.
It is. It won't determine pseudoprogression in the process of the activity, but it will determine it after it's happened.
And you might have touched on this briefly because you said, okay, how will a PET CT actually change my treatment? Again, we said 87.5% of the time, the statistics of the cancer agency show it absolutely changes the treatment because it changes the grading. It changes.
Gives you real-time versus serial imaging, tells you individual SUV values, and it's able to detect pseudoprogression after it's occurred.
Right. So one thing you didn't mention, but I can only imagine it's a significant factor, is a surgical perspective where because of the accuracy of this scan and how well it detects what is cancer and what isn't.
Good point. Yes.
Even if you're going to go have a biopsy taken, say for genetic testing, you want to make sure you get a good sample. A PET CT makes sure that the surgeon is digging in the right place and getting the right tissue.
Yes, so we do see that a lot. We see surgeons doing biopsies of benign tumors because they just didn't read the PET CT that was even done.
Yeah. Okay,
so,
oftentimes it
isn't done, and they get a inconclusive biopsy.
Yeah.
So definitely PET CT. It should be your initial part. And if a doctor tells you that it's not going to change the way you're treated, you educate.
Yes, send them a link to this video because there's lots of reasons.
Or just repeat those points, yes.
Yeah.
And so, sorry, I'll have to write in biopsy accuracy. Thanks for doing that,
I do. Yeah, you're welcome. I just know that surgery,
options,
that does make a big difference. And a lot of times once you may have been told that your tumors are inoperable, but following up your treatment with a PET CT, you might actually see, wow, because I had genetic testing, I got on the right treatment, my tumors have shrunk
so much,
and now it is operable. We've seen that happen.
We
time
do.
and time
We see that. I just saw that the other day, actually.
So everything that Alex has talked about today, all the diagnostics, and then all of the research and looking into the most current clinical data, they can all be used, in various time spaces in kind of a cyclical fashion. And that's why, one of the things that I hear you saying often, and that the ASCO post is echoing, is that cancer is quickly becoming a if not curable for everyone, a chronic but manageable disease, because you can just continue to use these diagnostic tools and these targeted therapies and immunotherapies to respond appropriately to what's happening in the moment in your body.
So is there any questions?
Whew.
Oh, I see a question.
Okay. Well, I think I got 1.5.
No,
right.
You did good. You passed.
Right.
You got at least 80%.
There were some trick questions there for sure.
And they're trick answers, and that's the problem.
Yeah.
They're misleading answers because a patient is asking one thing and the doctor is giving a straw man answer.
Right.
And so you can expect that. And the way to get around that is to clarify.
Start back with what diagnostics were done. What have you looked into?
What exactly are you saying when you say this? Are you saying what I asked you, or what exactly are you saying?
And it is important. Like in conversations like this, I just feel it's really important to acknowledge that while we're talking about some of the things that your doctor might say that aren't accurate, in no way, shape, and form are we suggesting that your doctor is deliberately trying to mislead you.
No. It
Not
could
at
be
all.
misinformation. It could
Most
be
of the
policy.
It's,
You know, it
yes.
could be many different
Well, there's a
things.
certain amount, only a certain amount of time these folks have for your case.
Mhm.
And Alex was talking earlier about the tens of thousands of publications that come out every year. So it's really,
Much more,
we have
yes.
to have empathy.
Much more,
I'm not
tens of
saying
thousands.
settle and be okay with it. I'm saying let's have empathy for what oncologists are doing with on the front lines.
They are.
And just gathering and providing them with this information and holding them accountable to have these answers will really help them help you, and it will help them help other people as well. So you're doing them a favor to question them on this stuff. One of the things that you didn't mention, but I hear a lot, which makes me really sad, is, you know, we'll talk with someone about all of these possibilities and how precision oncology can help them. One of the first things that they might say is, well, what if my doctor gets mad at me? Or what if my doctor refuses to treat me? Your doctor might have a response to being questioned. Again, not because they're not willing to look at new information, but because they think they're giving you the most current and accurate information. So they don't really understand.
And you have to understand too that, sorry to interrupt you like that, but you have to understand too, a doctor is just reading the protocol from a book. It's not his own personal choice.
Right.
It's the protocol written for them. He may have all kinds of ideas that he would love to give you, but this is what he's allowed to give you, and this is what he's allowed to tell you about.
That's right. And the most important thing for you to remember is, regardless of what you're being told there, what we see time and time again over 10 years working in this field, in precision oncology specifically, is that when Alex and his team present your oncologist with all of this diagnostic stuff that we just talked about and a list of treatments that are going to be more beneficial for you, because of the evidence that has been gathered, your oncologist can now change their treatment plan. They have the information now that they didn't have before. And the quality of that data gives them confidence in providing you with something innovative, or just something, it might be 5 years old, but something they hadn't thought to prescribe for someone with your type of cancer. So it's true in their heart and in their head when they say there's nothing more. I'm telling you what the best is, based on the data that they have. And what we see time and again is oncologists can't keep up with everything. They don't know what's possible. So you have to go out on your own. You have to get someone like Alex and his team to gather the evidence for you, all the peer-reviewed journal data, all those FDA-approved testing resources, and then your oncologist will have confidence in modifying your treatment plan. So there's a little bit of legwork for you, but that's what Alex and his team are here to help with. But don't take no for an answer.
No.
And your doctor's not going to fire you. They're not able to. What they can say is, this is what I have to offer you. If you're not interested in that, I can't help you. But as I just went through with you, that's when you say thank you very much, and you go and you speak to Alex, you get all the genetic testing data, and you go back to your doctor with a couple of pages of a treatment plan with treatment options outlined and all the data you need, and suddenly they're able to offer you some other things.
Yeah, and what we're typically offering is just what their more successful peers are doing in different centers.
Well, yeah, sure. But peers who have a little more freedom, probably.
Or just who are specialists in that particular area of treatment.
Yeah.
You know, they have specialties.
Yeah.
I think an important thing to mention is a large percentage of our clients and patients are doctors, oncologists, doctors, GPs. We have a lot of doctors as clients.
Actually, I wanted to mention that
too.
Yes, exactly, and they don't settle for standard care.
Yeah, they don't.
No.
Not typically.
No. But what I wanted to mention, you were talking earlier about getting all of your medical records. It was the very first thing Alex said, if you're just joining us now, or you might have missed it. He said, make sure right off the bat that you get copies of all your medical records, and then you keep getting them every time you go. Make sure that you have the most current file, because there's a lot of information that goes missing. There's a lot of things that don't make it into the file for some reason. We have, as Alex just mentioned, numerous clients who've worked in the healthcare profession. And one of the things that they all do without fail is bring a complete paper file of all of their medical records to every single one of their appointments with their oncologist, because they know that it's equally possible that they're going to show up and the doctor doesn't have this most current test data or doesn't have a report from someone like Alex or the latest test information. So be your own advocate. Make sure you ask all these questions. Make sure you get assertive and clarify what's actually being said, what's actually being done. Remember what's possible based on what we've talked about today. Carry all your data with you in paper form. Annoying as heck, I appreciate it, but this is your life we're talking about. And these are just some simple strategies that you can do that are going to drastically change how your cancer turns out. Okay, I think we've covered everything. Was there anything else you wanted to?
No, I think I've covered everything.
Okay.
Yes.
All right. Well, thank you very much for joining us.
There.
Oh, we do. Oh, sure. Okay. I thought you had maybe covered that already, but it's very specific.
Well, we have.
So, yeah.
But I think this is a great question.
Okay. So we're not quite done with you yet. Claire was wondering. She said her doctor told her that genetic testing is not going to show the reasons for her cancer, so there's no point in getting it.
Yeah, and I think the doctor is correct there in their terminology. Once again, Claire, you need to ask what the doctor means by that, and you need to ask with clarity and bring up the list that we provided you with earlier. So what the doctor is saying is the reasons for your cancer. In other words, what caused those genetic mutations, they don't know. Was it a chemical exposure? Was it, what was it? Was it, a genetic inherited circumstance? Was it exposure to chemicals? Was it exposure to radiation? What happened? Of course, it's not going to show that. But what it will show is the actual genetic features that are causing your cancer. And so there's a bit of trickery there. The reasons refers to, what has actually caused those mutations, whereas the causes refers to what is actually causing and driving that cancer.
So, for example, if I worked, say, as
a trick answer.
If I worked as a greenskeeper for 30 years, exposed to all sorts of pesticides and things like that, and then I've come down with some sort of cancer, genetic testing isn't going to show that was absolutely 100% because of your work as a greenskeeper.
Exactly.
But you will, through genetic testing, be able to see some mutations in your DNA, those molecular features, that there might be some data that shows, oh, this actually often happens for people who are frequently exposed to this pesticide. So your doctor would be reluctant to say, absolutely, it was your job that did that. But that, as Alex is saying, is kind of not the point. The point is, once you identify those molecular features, you now know what is driving your cancer. And there are many hundreds, Alex says thousands, but he knows best, of targeted therapies and treatment options once you know what your features are. So, yeah, so the wording of that is kind of tricky, isn't it, as you say?
Suspect.
Yeah, okay. Well, I'm glad that you clarified that. That's good. Thank you, Claire, for asking that. I'm really glad. And thanks for joining us today. So, folks, really, this is quite a quagmire.
Yes.
And when you have cancer, you don't necessarily want to be trying to figure this stuff out for yourself. You can certainly watch and rewatch this video. And on our website, ctoam.com, Cancer Treatment Options and Management.com, there's a link on many of the pages to access a webinar that talks in more details about the certain benefits of precision oncology and other things that you might want to know if you want to advocate for yourself and really make sure that you're covering all the bases. Alex also has a YouTube channel. It's called thecancerguy.com. We have playlists for all different types of cancer and playlists that talk about genetic testing and chemotherapies and innovations in all sorts of treatments. And we're constantly adding videos every week. So go visit there, click the subscribe button so that you'll get notified when there's new data added to playlists of interest to you. And ultimately, of course, Alex and his team are here to help answer your questions. You can have hourly consultations and, go advocate for yourself, come back, regroup, have a chat, go do some more and come back. Or you can just turn it all over to Alex and his team and they'll take care of all of this stuff for you, including liaising with and advocating for you with your oncologist to make sure you get the best care. So how much or how little support you want, we have you covered. So thanks very much for joining us today. We hope you got great value. Please do leave us a comment when you watch this video. It's really important for us to know that people are benefiting from this. And if you have any questions, we want to make sure you get your questions answered. So we'll follow up with you. Thanks again for joining us.
Thank you for watching Cetome TV. Subscribe below and stay informed.